anytime we give neoadjuvant or perioperative approach, there is, in Checkmate 816, it was up to 3 cycles of chemo-nivo. In the perioperative trials, it was up to 4 cycles. So there is an inherent delay to getting that patient to surgery. And there's an inherent attrition to surgery. And that attrition rates are roughly about 20% of patients that don't make it to surgery. And but when we look at phase 3 randomized trials, and the only one I know of that looked at head-to-head upfront surgery alone, upfront surgery then adjuvant chemo, or neoadjuvant chemo, then go to surgery. And this is before the era of targeted therapies and IO, and that's the NATCH trial and the Spanish lung cancer group trial. And in that study, they looked at, one of the things they looked at was attrition to surgery. And across the board, regardless of the intent to treat, there was about a 9% attrition in all 3 arms. So we don't talk about attrition to surgery in the adjuvant IO trials, and there's been 3 IO adjuvant trials in early stage lung cancer, which have included Empire 010, Keynote 091, and then BR31. And all 3 of them, the randomization was following complete resection. And because of the trial design, we don't talk about attrition to surgery in the adjuvant trials, but they clearly exist when you look at like the NATCH trial. And so I think the attrition rates are probably overestimates what the real attrition rates are from the neoadjuvant approach, because there's an inherent baseline attrition regardless of your intent to treat. Delay to surgery is a little arbitrary in the sense that the protocol defines a window for surgery. And in most of the phase 3 registrational trials in the early stage setting, it was at 6 weeks, roughly 6 weeks. AEGEAN had the shortest at 5.7 weeks. All the other trials was at 6 weeks to go to surgery, and Keynote 671 was at 8 weeks. So the rates are variable because the protocol defines a window differently. But most patients make it to surgery, and there was no difference from the control chemotherapy alone arm. So I think the surgical delays and the attrition rates are acceptable rates. When you look at progression of disease and adverse events that have prevented patients from going to surgery or delays to surgery, those numbers are in the low single digits. So for the most part, AEs and progression of disease account for a small minority of patients when you look at the total cohort altogether. So I think overall it's safe, and I think those are acceptable numbers for attrition and delays to surgery.